Hi everyone, I'm Dr. Vilma Irazola and I'm the director of the Department of Research in Chronic Diseases at the Institute for Clinical Effectiveness and Health Policy in Argentina, which is an academic institution affiliated with the University of Buenos Aires. In this lecture, we will be talking about study designs that are used in implementation science. At the end of this lecture, you will be able to describe the most common study designs used in implementation science, explain the concept of pragmatic trials and how they are different from more traditional explanatory trials, and finally, understand the concept of hybrid studies, which, as we will see, are unique to implementation science. Let's start then with the different study designs that we use in implementation science. In implementation science, we usually use mixed method approaches. Mixed methods focus on collecting, analyzing, and merging both quantitative and qualitative data. The central premise here is that the integration of quantitative and qualitative approaches provides a better understanding of complex implementation issues that comparing either approach alone. So, in implementation science, we frequently use different qualitative designs, in particular participatory research techniques. Participatory research is a method of qualitative research that is designed and conducted in close collaboration with key stakeholders and involves engaging with the target population from the very beginning and throughout the implementation science project by conducting different activities, including workshops, in-depth interviews, group discussions, observations, and so forth. These and other qualitative research methods are of great value in implementation science to assess needs of different populations, to understand contexts across very diverse settings, to elicit stakeholders' perspectives and needs, inform intervention design and implementation, understand mechanisms of change, provide inputs on implementation processes, gain insight into the implementation effectiveness, and also contribute to theoretical development. In terms of quantitative designs, we use experimental designs, including both individual and cluster randomized controlled trials, quasi-experimental designs, such as before-after studies or time series studies. We also work with data from observational studies, such as cohort studies, case control studies, and cross-sectional surveys for different purposes, real-world evidence and analysis of existing databases such as electronic medical records and surveillance systems. It can bring useful information as well. Economic analysis of different types such as cost-effectiveness analysis, return to investment analysis, and so forth are also frequently applied. So, this list of study designs is not exhaustive, but I'd like to get across the concept that in implementation science we use a wide variety of study designs, both quantitative and qualitative. Now, an important point that I'd like to highlight here is that when we talk about randomized controlled trials in implementation science, in general, we refer to pragmatic trials. And what are pragmatic trials? What are they different from traditional explanatory trials that are often used to test, for example, the efficacy of pharmacological interventions? Well, let's see some of these differences. In terms of eligibility of the population, traditional or explanatory trials usually have more exclusion criteria, which contribute to the internal validity of the study, but limit its external validity. On the other hand, pragmatic trials usually have few exclusion criteria, and because of that, higher external validity and generalizability of the results. In the same way, more traditional explanatory trials usually include a limited, very restrictive range of individuals, providers, or settings, while pragmatic trials include a wider range of participants, gaining again in generalizability of their findings. Traditional trials, depending on the study, use active or placebo controls, while pragmatic trials usually use active controls, such as usual care or enhanced usual care, for example. In trials, efficacy, more traditional trials, we usually measure clinical or even physiological outcomes to measure the efficacy of the intervention, while in pragmatic trials, we also measure clinical outcomes, but these trials are more focused on person-centered outcomes and process measures that help us better understand how different interventions or strategies of implementation work. In general, in traditional trials, the follow-up is shorter and more intensive. In pragmatic trials, the follow-up period tends to be longer. For example, when our research question includes factors associated with sustainability, and less intensive to make them more feasible, again, in real life conditions. Traditional trials are often blinded. Let's think, for example, of pharmacological trials, while pragmatic trials, which more commonly involve non-pharmacological interventions such as behavioral or system interventions, are not blinded. Finally, traditional explanatory trials are frequently randomized at the individual level. On the other hand, pragmatic trials can be randomized at the individual or cluster level. Cluster randomization is more common in these pragmatic trials because they are frequently related to interventions at different levels: the individual level, the provider level, the system level, and so forth. Finally, let's talk now about hybrid designs, hybrid studies. What are hybrid studies? These are studies that simultaneously consider clinical or health outcomes and implementation evaluation. They are unique to implementation science. According to the hierarchy of clinical effectiveness or health outcomes versus implementation in the study, we can distinguish three types of hybrid studies, of hybrid designs: 1, 2, and 3. The three types of hybrid studies vary based basically on the amount of emphasis on clinical or health effectiveness versus implementation outcomes. A type 1 hybrid focuses primarily on the clinical effectiveness outcomes of the intervention, while exploring the implementability of the intervention. In this type of hybrid study, we test the effectiveness of the intervention, that is, what are the clinical or prevention outcomes, that's the primary aim of the study, and at the same time, we explore barriers, facilitators, and we measure some process indicators as well. But the primary aim of the study is still clinical effectiveness, clinical outcomes. Implementation aspects are secondary aims, and we study them because we know that this information will be useful when we think of implementing the intervention in the real world. Important, we use this type of hybrid when we need to generate evidence about clinical effectiveness. We don't have enough evidence yet about the effectiveness of the intervention, so we need to test that, and that's why this is the primary aim of the study. In type 3 hybrid studies, it is the opposite. We test implementation strategies, often in a comparative way, comparing different implementation strategies, while measuring clinical outcomes at the same time, and trying to understand those clinical outcomes as a function of adoption rates and fidelity, which are, as we have seen, key implementation indicators or outcomes. In type 3 hybrid studies, then, the primary outcomes are implementation outcomes, and clinical effectiveness or health effects are secondary aims. Important here, we use this type of design when we need to generate evidence about what is the best or what are the best implementation strategies. We already have enough evidence about the clinical effectiveness of the intervention. That is not our main problem. Finally, we have hybrid type 2 studies, which are in the middle. In type 2 studies, both clinical or health and implementation outcomes are equally important. Both are at the same level of hierarchy in the design. That's why we have co-primary aims here: effectiveness and implementation. These studies always need explicit measurement of implementation outcomes, for example, reach, adoption, fidelity, at the same level of importance of the clinical outcomes. A hybrid type 2 is ideal when studying interventions that already have evidence of effectiveness in other settings or populations, but not in the current context or population where we will apply the intervention. So we have uncertainty that there will be a similar clinical benefit, and we need to measure that. For example, there may be data to support the effectiveness of an intervention in hospital settings, but not yet in a primary care setting. So we have a lot of information, yet we need to know more about effectiveness in this new context. As a summary, in hybrid type 1, the primary focus is on testing the clinical effectiveness of the intervention. The secondary focus is to explore implementation-related factors. This type of hybrid could be a pragmatic effectiveness studies plus a process evaluation, for example. The primary aim is clinical effectiveness. The secondary aim is related to implementation outcomes. A hybrid type 1 is indicated when the evidence of the clinical effectiveness of the intervention remains limited. At the same time, while testing effectiveness, we take advantage of the opportunity to explore some implementation issues. It's not enough by any means, but we can learn about potential implementation challenges from evaluating the delivery of the intervention during the trial. In a hybrid type 3, the primary focus is on implementation outcomes. The secondary focus is to observe or gather information on the clinical outcomes. A hybrid type 3 is essentially an implementation trial plus an evaluation of clinical outcomes. The primary outcomes are implementation outcomes such as adoption, fidelity, sustainability, for example. The primary outcome then is implementation, secondary outcome, clinical effectiveness. These designs often compare different implementation strategies. For example, clinics might be randomized to receive different sets of implementation strategies, perhaps varying in terms of who deliver the intervention. Let's say, for example, nurses versus community health workers, or the intensity of the intervention. For example, different frequencies of text messages, and so forth. The secondary clinical outcomes are observed and are related to the level of adoption and fidelity produced by the different implementation strategies, which are again our main focus. They are very useful, for example, to test scaling up strategies. In a hybrid type 2, both clinical outcomes and implementation-related factors are equally important. Both are at the same level of hierarchy, and that's why they are co-primary aims. As key messages, remember, in implementation science, we use a broad range of study designs, both quantitative and qualitative, and most often mixed method approaches. Hybrid studies have a dual focus on implementation, evaluation, and clinical or health outcome effectiveness. There are 3 types of hybrid studies, 1, 2, and 3. The difference between them rely on the hierarchy of clinical or health versus implementation outcomes. In hybrid studies, we can use different study designs, such as trials, quasi-experimental designs, and so forth. The difference between hybrid 1, 2, and 3 is not related to the study design used, but on the hierarchy of the outcomes, that is, clinical or health outcomes versus implementation outcomes. Thank you very much.